So we're going to compare two clinical constellations that are kind of in many ways similar but opposite. And if that doesn't make sense, then I'll kind of just dive straight into it. We're comparing Cushing's Triad to toxicity of tricyclic antidepressants, so TCA toxicity. And it might seem kind of odd and random, but you'll see that they have kind of similar things to look out for, but opposite presentations. So for Cushing's Triad, first of all, let's define what Cushing's Triad is. Cushing's Triad is a constellation of symptoms that we see in, oftentimes you'll see it in the context of, or it's really due to increased intracranial pressure. Now, we know there's many things that can cause increased intracranial pressure. The classic one that comes to mind, aside from a space-occupying lesion like a tumor, is a subarachnoid or intracerebral hemorrhage. So a brain bleed that's increasing the amount of blood in the the blood component of the cranium, and so then that blood will press against brain structures and increase intracranial pressure and result in these problems. So first of all, in Cushing's Triad, we're going to see hypertension, which I will write as just HTN. So that's increased blood pressure in Cushing's Triad. And why do we see that? Well, think about what's going on underneath. You have increased intracranial pressure. So when you have increased intracranial pressure, that means that blood inside the cranium is pressing outwards. And so that makes it more difficult for blood to be delivered into the brain from the aorta, from the systemic arterial vasculature, right? And so what your heart will do is the pump will decide, okay, well, in order to overcome this increased intracranial pressure, what the heart will do is it will increase the driving force of blood going towards and into the brain, and that manifests as an increase in blood pressure, and that can result from essentially the heart will and the vasculature will contract, and you'll have that alpha 1 agonism, and you will increase the blood pressure that's shunting blood towards the brain. So you'll see hypertension. The other thing that you will see is that you'll see a decrease in heart rate. So you'll see bradycardia, right? So you'll see bradycardia as a reflex to the increased blood pressure. So remember that when blood pressure spikes, in order to maintain homeostatic balance, the heart will decrease the rate at which it pumps. So you'll have what is called reflex bradycardia. So important to note that is in response or reflex to the hypertension, right? The increased blood pressure. And so then the last thing that you're looking for in Cushing's Triad, because it's three things, is you're looking for irregular respiratory rate. So the respiratory rate is irregular, or irregular respirations. And why? Well, think about it again. Increased intracranial pressure, that increased pressure is going to push against several parts of the brain, including the brain stem, and that's going to cause a kind of a transient ischemia of the brain stem. And so what that manifests as is you'll have periods of very fast respirations as the patient tries to catch up on the oxygen that it requires, and then followed by periods of apneic or apnea, which means no respirations. And so it will be these irregular kind of on and off breathing that you see. This is denoted as Cheyne-Stokes breathing. So Cheyne-Stokes breathing. If you see a patient breathing this way, that could be due to compression of the brainstem due to increased intracranial pressure. Because why the brainstem? Our respiratory centers are located in the brainstem. Okay, and so that's Cushing's Triad. Now for tricyclic antidepressant toxicity, we'll kind of see the opposite in many ways, where instead of having hypertension or increased blood pressure, we're actually going to see a decreased blood pressure, right? So this is also known as hypotension. And so why do we see decreased blood pressure? Well, one of the tricyclic antidepressants, as it's in the name, they're antidepressants, so they treat depression, but they're one of the old school ones. And the reason that they're not used so much anymore is because they have quite a few adverse effects, because they, in addition to blocking serotonin and norepinephrine reuptake, they have several other kind of effects that were never really intended, such as they block alpha-1 adrenergic receptors that allow your vasculature to contract, and so that blockade of alpha-1 adrenergic receptors causes hypotension. And they have other effects as well, and so what you'll see is that you'll have this kind of orthostatic hypotension that results from this. And so then for the heart rate, so remember the heart does the opposite of what the blood pressure does to maintain that homeostasis of the heart and vasculature. So you'll see reflex tachycardia here. So reflex tachycardia. So increased heart rate, right? Increased heart rate rather than reflex bradycardia. You have reflex tachycardia. And then for your respiratory rate, what you're looking for here is a suppressed respiratory rate. So your respiratory rate is going to be down. You're going to be breathing less than normal. That's because another one of the receptors that tricyclic antidepressants antagonize is these histamine H1 receptors, which cause central nervous system depression and result in sedation of the patient. And so you'll see this respiratory rate decreased in these patients rather than irregular as you see in Cushing's Triad. It should also be noted that the reflex tachycardia there's also a component of it that is not reflex, but also is driven by yet another receptor that tricyclic antidepressants antagonize, which are central and peripheral muscarinic acetylcholine receptors. By blocking those, you'll see the effects of antimuscarinic toxicity. So you'll see that instead of bradycardia, you'll have tachycardia from an increased sympathetic tone in the body. So it's not necessarily just reflex tachycardia. It is a tachycardia that is also driven by a direct blockade of these muscarinic acetylcholine receptors.